So, hello, my name's Rebecca Heath. I am delighted to share with you via the video presentation link my research that I did in Papua New Guinea on asthma and how evidence-based medicine and program change model were used to try and improve asthma management in a low-income emergency department. My apologies that I can't make it in person, and thank you for taking the time to look at this video presentation. So, as an overview for the presentation, we'll just talk a little bit about the background, the context, our research objectives, the methods, our results, some of the limitations, and just a quick conclusion and summary at the end. So the background and the driver really for this is that there is a lot of evidence-based guidelines out there for the management of asthma internationally. The British Thoracic Society, Scottish guidelines, as well as the Australian guidelines, are both recently been updated and very helpful. But what we don't have is research on how to put those guidelines into practice, particularly in a low income or resource poor setting, or any of the prevalence or current management that happens in the developing world and low income settings in the Pacific, so particularly in Papua New Guinea. No research has been done on asthma in Papua New Guinea since 1996, unfortunately, so there isn't a lot known about it. Back in 2014, the World Health Organization said that asthma is a global health priority, and with the advent of the Global Asthma Network, which unfortunately PNG is actually not a part of, even though the World Health Organization recommends that all countries are, the recognition that asthma has a significant impact on global morbidity and mortality is increasing, and a lot of the statistics say that most asthma deaths unfortunately happen in low and middle income countries, which is not surprising when you will go on to talk about the results of what we found and how asthma was being managed. So the Papua New Guinea context, and this study was done on the north coast of PNG in a small coastal town called Madang. But in Papua New Guinea, about 40% of the population are living below the poverty line on less than $1.25 US a day. It's got really poor infrastructure, and that's difficult because you've got very rugged terrain. There's offshore volcanoes, dense tropical forest, and a lot of the population really struggle to access medical care. And most work as subsistence farmers. So where we did the research was Modelon Hospital in Madang, and that is the only government hospital in the province, and that supplies about 700,000 people. There are a couple of healthcare and aid posts, but they sometimes don't function due to staffing issues and funding issues. So this is the main medical facility for almost 750,000 people. Unfortunately, the hospital has inconsistent electricity and intermittent running water. Both of those have a huge impact on delivering medical care, as I'm sure you can imagine, particularly in the relevant and how that's relevant to asthma is that we can't run a nebulizer with no electricity, and you can't wash out the face masks to deliver those nebulizers if you've got no running water or cleaning products. And there's a lot of multi-drug resistant TB, so that does have a knock-on effect if you can't wash the masks. And we'll go on to talk about the fact that people weren't using spacers, so having an alternative when you rely on an electricity-driven nebulizer is important. So our aim was to improve asthma care in what really was a complex low resource setting, but at the same time maintaining cultural sensitivity and having that as a real key theme throughout the whole piece of work. So we had a 3-phased approach within an action research framework, and action research really is about both participants and the researcher learning as they go along, being involved in changes and understanding changes in the context within which they happen and why they happen, and how that then has a knock-on effect. So phase 1 was trying to find out what is being done at the moment and how asthma is actually being managed in Madang. And then we went on to the 4-step model of programme change, which we'll come to talk about, in trying to align what was happening with the international evidence-based guidelines. And then at 3 months we reviewed what staff thought about the changes with an anonymous survey, and the piece of work yet to be completed is what happens at 6 months down the track, and seeing whether those changes have stuck. So the results of our initial survey, we had 35 participants with a diagnosis of asthma. We excluded those with TB, bronchiectasis, known cardiac disease, and had a fairly good return in 2 weeks that we ran the pilot study for. Most people were between 16 and 50 years old. Most people came to the department between 1 and 4 times a month. 82% had previously used a nebulizer, 23% had heard of or used a spacer. Most people use an inhaled form of salbutamol or oral salbutamol. 37% had their observations done on arrival. It's not easy to find a SAPS probe, it's not easy to find a blood pressure cuff, and the situation in which the staff work is challenging and stressful, and that's not actually an unsurprising figure for the number that had their obs checked, having worked in the department. So treatment in ED, just under 10% received oxygen. The oxygen is in bottles. They're not always full, so you may or may not be able to give oxygen in the department. 97% received nebulized salbutamol. 46% had IV steroids. 23% had oral steroids. 40% had IV antibiotics. 1 patient received adrenaline, and 37% of patients were either admitted to the emergency department or the medical ward. So on discharge, those patients often got a combination of short-acting bronchodilators. Half of them left with oral aminophylline. 60% of them left with oral or inhaled salbutamol. Only 17% had oral steroids, and that was a really variable dose range and duration range, between 4 and 40 milligrams, from 1 to 5 days. 80% received antibiotics, and nearly 50% were discharged on paracetamol. There was no spacers used, no preventative inhaled steroid therapy, and no asthma action plans. So we used a model for programme change to try and follow. Stage 1 was exposure, 2 adoption, 3 implementation, and 4 was practice, and the hope is that you get programme change and programme improvement as part of that. So it was originally designed by Simpson for substance abuse treatment back in 2002, but we thought it would be useful to follow an actual guideline and framework. So exposure, part 1 of that programme change model, was about educating the staff, and that was done through didactic teaching, about what asthma is, the pathophysiology, and going through the British Thoracic Society guidelines on the management of asthma that were released September of 2016, and looking at what we've been doing in the department and talking about the real key differences between our practice and the evidence-based guidelines out there that we'd ideally like to be following. So the next part of program change model is to have adoption. So thankfully all the ED staff were excited to be involved in the program, keen to be involved, but we had to get the go-ahead from the Director of Medical Services, and he was very happy for the program to go ahead, so it was officially adopted, and we went on to implementation. So we had several workshopping sessions where we came up with our own department guidelines, a prompt for how to diagnose asthma, the main things to look out for that are red flags that should prompt you to investigate for TB, malaria, and some of the other things that crop up fairly commonly in Medang. And then how to manage asthma in a moderate, severe or life-threatening chart, as well as introducing the steroid inhalers for the first time in the department. So most staff didn't know that they were an option for asthma treatment, even though they were in the standard treatment guidelines that the Papua New Guinea government released back in 2012. Helpfully and thankfully, the pharmacy at the hospital actually stocked them, but they'd just been going out of date and not being used, so that was great that we had access to those and could start using them. The other thing that we did was change the quick list prescription for discharge medications and removed a lot of the duplicates, standardised the dose of steroids, put a prompt in to remind people to think about whether they're in infective symptoms before prescribing antibiotics, and that Panadol doesn't really treat asthma, and so it took those off. So we rejigged the quick list prescriptions that people with asthma were getting, which was great. We also then tried to make spacers, because you can't buy them in Papua New Guinea, and to import them internationally is really expensive and just not an option. So staff found lots of IV fluid bottles behind the pharmacy department were going out of date and getting thrown away. So figured out the best way to make them to spacers, and lots of people had a lot of fun trying to do that. We'd rinse the bottles out because a lot of them, the fluids had dextrose in, hung them on the line to dry, and then would dispense them to patients. So great, because it's individual use, free because they were going to go to waste, and it was a really fun, cohesive management project for people to get involved in. We also created our own department asthma action plan to prompt people with which inhalers they should be using, when, how much, and at what point they should come to hospital, and staff translated that into Tok Pisin. We're very conscious that there are quite low literacy rates, so we tried to make it as pictorial as possible. And then stage 4, the program change model, practice, trying to put it into practice and maintain some momentum. Really excitingly, word of mouth spread around, and we had the provincial TV channel, Tumbuna TV, come and do a program feature on us on the news. And we had 2 press releases in the national Papua New Guinea newspaper, which is really exciting. So the final phase, the results, we had an anonymous survey for staff in the department to fill in, and excitingly that had a unanimously positive response about asthma. They all felt that the way they managed asthma had changed. Anecdotally, they felt that less antibiotics were being prescribed, more steroid inhalers, more spacers, and were excited about the project. The only reservations people had were about the longevity with manpower and funding, and not having someone allocated to run the program after my time in Papua New Guinea was due to finish. So it'll be really interesting to see in 6 months when we go back what changes have stuck, and whether there is still that ongoing difference, and whether the changes have had long-term positive outcomes. There are quite a few limitations. So it's a really underdeveloped information and data collection system. There's no 24-hour triage. Patients all have their own paper notes. Sometimes they'll bring their own book, sometimes they'll bring someone else's if they can't find it or forget it. So you never really know what someone's history is. You've got to check very carefully, and there's no centralised record keeping system, no way of checking how many people come to the hospital with asthma, no way of checking more mortality related to asthma, because a lot of the deaths are recorded as an unknown cause in the death record book at the hospital. Lots of patients don't have birth certificates, so ages are just a guess. And due to lack of education, patients may have a wrong diagnosis and may actually have another medical problem, which is tricky and means that their treatments might not work if actually it's heart failure rather than asthma that's causing them problems. We ran the study between 8 a.m. and 5 p.m. Monday to Friday when I was in the department, and at the same time the paediatric outpatient department runs, so we didn't have many paediatric patients, and as a result of that inherent bias in our study, we made the guidelines for adults only. So in conclusion, we felt that staff awareness about asthma improved and their asthma management improved. It was the first time that the department guideline had been created, and going through that process with staff was a really valuable learning experience, and a great strategy for trying to increase awareness about evidence-based guidelines and checking practice. It'll be exciting to see what happens in 6 months' time, and it was also interesting at least to have some data and information on the current management in the Pacific, as well as trialling a change management programme. So I do owe a big thank you to Model On Hospital, the emergency department, the Director of Medical Services, Dr. Vincent Attua, as well as Dr. Georgina Phillips, who is a FACEM in Australia, Dr. Niven, who is a world-renowned asthma specialist who very kindly offered advice with this project, and of course to AVI, the Australian Volunteers International, which is an AVID programme funded by DFAT, the Australian government, who supported my time working in Madang. So lots of thank yous, and thank you to you for watching my video presentation. We hope that the message of asthma management and evidence-based programme change floats around in a bottle to the islands of the Pacific. So I hope you have a good day, and thank you again for watching.